Good afternoon, everyone. Thank you so much to the Scientific Committee for this opportunity. I'm going to present a case that I saw and learned during my training with Dr. Santosh Nava sir. And I've termed it as Pithos of Pandora because of what unleashed from the Pithos, that is our orbit, much like the Greek legend. So as we know, orbit is a Pandora's box. It can often present us with clinical cases which can be a clinical and therapeutic dilemma or an absolute clinical surprise. I'm going to present one such case of this 46-year-old gentleman who presented to us with swelling and bulging of his right eye for the period of 1 month associated with pain, which was gradual, progressive, increasing both in bulging and pain and redness. And there was no other specific history leading to this in the past that we noted. He was non-spoken, non-alcoholic, and there was no other systemic issues that he actually complained about, and we had asked him, and no other consultation sought, and no history of weight loss specifically, and no family history of cancer or no prior treatment that was taken. 2 months prior to his presentation, he looked like this. Absolutely a normal right eye, as you can see, and he looks absolutely healthy. So on examination, he had an obvious proptosis, which was of 9 millimeters. Bend and Valsalva test was negative. There was no dystopia. It was more of an axial proptosis. As you can see, there was severe solid chemosis, dilated blood vessels, but the cornea was clear. When we saw his ocular motility, it was restricted in all directions of gaze, and pupillary reactions were abnormal. His vision was decreased in the right eye, as you can note here, 6/24 and N18. And on his fundus examination, he had disc edema and choroidal folds. No nodes were palpated, and we also did a nasal examination just to rule out any nasal pathology for sino-orbital tumors, and no obvious nasal pathology was noted. So when we see a case like this clinically, when we open up the Pandora's box, many things we can think about. But when we go as a stepwise approach, we should always categorize them into inflammation, infection, and neoplasm. So I've just put up this slide here just to show what all lesions can simulate such a presentation. And I'm going to come back to it after I have taken you through the radiology of this patient. CT scan showed a heterogeneous intraconal mass, and MRI that we did also corroborated with the finding. It was a well-defined mass lesion, intraconal, heterogeneous, and hyperintense. As you can see, there's a peripheral solid enhancing component that is seen, and the extent is from the orbit to the orbital apex. Our specialist has actually marked the optic nerve, which seems to be displaced. And there is definitely a very gross central area of necrosis or mucoid degeneration that we can see here. This slide I've put up just when we see the radiology, what all can we think about? I have a schwannoma here, a neurocysticercosis, and VLM or a very aggressive malignancy that we can think about. So coming back to the slide, some lesions we can actually eliminate just by the age in which they present, like RMS or orbital retinoblastoma, some by their history. And we should always come up with a list of differentials that we should keep in mind when we are dealing with something which is not very straightforward that we are dealing with. So in this case, the provisional clinical radiological diagnosis that we kept in mind was maybe a schwannoma because of the onset and the progression of this case, which was kind of acute and leading to too much of inflammation. So we thought maybe it was a neural sheath tumor which underwent a cystic degeneration. And of course, we did keep an aggressive malignancy in mind too. And definitely a biopsy was necessary for diagnosing this case. Well, Pandora was very curious to know what was inside the box, and hence the evil was set out. But we held on to our curiosity because so much of inflammation was going on. We did not jump to orbitotomy or excision biopsy. We decided to treat the inflammation first that was going on and reassess the case. We did start him on steroids, but there was absolutely no resolution that was seen. Second step that we thought about is, since it was well-defined intracoronal lesion, we thought that we'll do a cyst aspiration and see what the aspirate is so that we kind of get to know what the pathology we are dealing with. And we did a transcutaneous cyst aspiration. A total of 7 milliliters of aspirate was found, which was kind of like a frank blood. We sent it for cytology and microbiology. And the amusing thing was the chemosis or the proptosis did not settle down on table at all. And hence we decided to go ahead with a PET CT scan for the patient. This is the time when the evil actually unleashed in this case, and the cytology came out to be a poorly differentiated neoplasm with certain differentials. And along with that, the PET CT scan was totally clinically surprising. A seemingly healthy looking male had so much of hotspots going on in his body. As you can see, there's a hotspot in the orbit and a very diffuse FDG-avid lesion that is seen in the rectum here. So the working diagnosis according to the PET CT scan was a rectal primary with metastasis. Sigmoidoscopy was done along with the collaboration of our oncologist in the super specialty hospital, and it came out to be a round cell infiltration which was possibly malignant, or maybe an adenocarcinoma or a small cell carcinoma. The pathology finally revealed pigment-laden cells, HMB45 positivity, which proved it to be a malignant melanoma. Hence, the final diagnosis was an orbital METS, probably a primary from the rectal malignant melanoma with diffuse metastasis. We did go back and dug into the history, and he did recount 2 episodes of abnormal bowel bladder movement with bleeding per rectum, hence proving it to be a rectal primary because it presented before the orbital lesion and a diffuse metastasis that we were dealing with. Well, we went ahead with immunotherapy along with our oncologist, and he was started on pembrolizumab, and EBRT with concurrent temozolomide was started. We all know that it is a very advanced and aggressive kind of a disease. It has a poor prognosis, and unfortunately, the patient succumbed to the disease. When we see the survey of orbital tumors done by the Shields group and other studies that have been published, we know that orbital METs are around 3 to 7% of the lesions that we deal with. Melanomas have been documented, but the most common sites of metastasis would be something that we think about is breast, lung, or prostate. Even when we see, this is one of the recent papers which deals with the survey of the orbital METs, which is a good paper that we can read. And when we see the melanoma that metastasizes to the orbit, most of them are either cutaneous or choroidal melanoma, and rarely alimentary tract melanoma or a rectal melanoma has been documented. This is one detailed paper which deals with a similar kind of a presentation, which has been published in IJO. That is the only paper I could find about this kind of a disease. So what makes this case worth a discussion? Well, the rarity of it. Orbital METs itself are not so common. The primary and the secondary location of this case was extremely rare, and anorectal melanomas are itself less than 1% of all anorectal malignancies. The points of contention throughout the treatment and the journey of this case was the age, the seemingly healthy male that we were dealing with, the differentials that we had to keep in mind, and the timing of the biopsy was also a challenge because of so much of inflammation that was going on, and the treatment strategy that we employed for him to help him. And the take-home message would be that orbit is definitely a Pandora's box. We can have very straightforward pathologies or very, very complex and difficult cases that we deal with. But if we go step by step and with caution, we can reach to a diagnosis. And definitely accurate history is a key to solving all these mysteries. And hence, we should definitely dig into the history very well. And all these are complex cases which require multidisciplinary approach, and close collaboration with the oncologist and other specialties is definitely needed. These are my references. Thank you so much for your patient listening.
That was a fantastic case, and to be very honest, I'm sure none of us would have even ever thought of it. One. But the biggest conclusion I get is no tumor or no disease nowadays follows any rules or regulations described in the books. So I think we ought to be even more stringent in our evaluation and history, which I think is really, really important, which cannot be overemphasized in this particular case. Excellent presentation and excellent take-home message. Besides the case, I think we all have to now resort to good history taking and good examination, and also coordinating with other subspecialties, which we often miss. Thank you very much.
Thank you, ma'am.
May I request Dr. Siddiq to please conclude with his comments.
Thank you, Dr. Asa. Actually, I'm not an oculoplastic surgeon. I'm a neuro-ophthalmologist, but by sitting here, I saw all the speakers have been delivered the topics very clearly. I think very practical for the ophthalmologists for their daily practice. And I also give the appreciation to the audience that still sits until the end of the session. Thank you. That's all.
Thank you. Seema, hand over to Seema.
Thank you, Dr. Siddiq. Thank you, everyone on the dais here, for your valuable time, and to all the speakers for such a very, it's very difficult to cover orbit in a short span, but thanks for all the, wonderful talks and sharing your experiences.
Dr. Seema and Dr. Usha and the people on dais, I mean, may I request you to convey the message? When is it so very important to refer a case of proptosis to the specialist and not just sit on it? We can just...
For me, at least I'll stick on to my topic, optic nerve sheath fenestration. See, often neurologists do not know that oculoplastic surgeons do this particular procedure, number one. And they often try all the aspects and then send it to us. This is the reason why there's a high failure in getting back the vision. So I think it's important for us to present in whatever forum possible, even if we have just a handful of audience, keep presenting and keep getting the other specialists involved. That's number one. I think any case of proptosis, I think it's best we educate our ophthalmologists first to refer it to an oculoplasty person before they start intervening.
And Dr. Seema, inflammations, because it is seen by everyone as a general ophthalmologist. When would you, say that it has to be referred to the
inflammation is
specialist?
one disease which is probably the most misdiagnosed and probably most inappropriately treated. Again, here it's important to go on a step-by-step approach, and the crux here is that we need to rule out any other pathology, because we know tumors can mimic an inflammation, infections can mimic an inflammation, and anything, probably any orbital disease can actually present like an inflammation. And we do see a lot of patients where the first-line treatment has been steroid even without a proper evaluation and a biopsy. And I think that's the point, again, as Dr. Usha mentioned, even before we go down to the rest of the group of ophthalmologists, even as oculoplastic surgeon, we need to be very careful what are the indications for biopsy before we decide that we need to start the patients on steroid. Because there are cases, Dr. Santosh keeps on talking about those cases where the tumors has been missed because the initial treatment has been with steroids. So that aspect, once taken care of, will definitely make things much more, better.
Thank you. Yeah, and we all agree that orbit is a Pandora's box, and more than eyelid and conjunctival tumors and lesions, which is very evident otherwise for your naked eye, orbit is something which has to be referred if at all there is even a very minimum doubt about the pathology, I think so. Thank you so much, Dr. Seema, for conducting this session well. Thank you, Dr. Usha. Thank you, Dr. Mohammed and Dr. Grover, for having you.